to Susie, our IHSO president, and she, along with Matt and Christina and Tracelyn, have really put all of this event together for you guys to bring in this wonderful speaker. So I wanted to first thank our board members for supporting the idea and really making this happen. And now I'm going to introduce Dr. Lee. She is within the Physical Medicine and Rehabilitation Department, and she's also the director of the University of Michigan Rehabilitation Engineering Research Center. The Technology Increasing Knowledge, Technology Optimizing Choice, or TICTOP group, which is focused on developing and evaluating mobile technologies to enhance health management and independence among adolescents and young adults with disabilities. She is also a PI or co-PI on several other grants, including the UN Spinal Cord Injury Model Systems and a Department of Defense study looking at resilience among individuals with spinal cord injury. Her primary research interests focus around self-management and enhancing health and participation and reducing healthcare disparities and costs among individuals with disabilities. Through identification of modifiable factors, development and validation of culturally relevant interventions, and implementation of tailored dissemination and knowledge translation strategies. So please join me in giving a warm welcome to Dr. Michelle Lee.
Thank you so much, Erica. Thank you for having me. I'm really excited about having this opportunity to talk and get up on my soapbox once again as I really talk about this area of the healthcare disparities faced by individuals with disabilities. I don't know if you need it, but I'm used to doing disclosures in terms of various positions and funding support, and then the objectives in terms of this presentation to really increase the recognition of health and healthcare disparities faced by individuals with disabilities, to provide a conceptual model, and to identify modifiable factors. But more importantly, to talk about our responsibility as members of a healthcare system, healthcare providers at various stages, in terms of thinking of what we can do to make a difference. So first I wanted to really talk about some of the disability and the disparities that exist. This is the International Classification of Functioning Disability and Health, or the ICF. That really speaks to how the disability or reduced functioning or activities of daily living or participation is not just related to a level of impairment or a problem with the specific body system, but rather it's influenced by both personal and environmental factors. They really influence the extent that an individual can or can't do things. And so when you think of wheelchairs, that is an assistive technology as part of the environmental factors that influences mobility and the ability to get around and work and do things. Personal factors may include things like education, health literacy, factors in terms of that influence, once again, this continuum of participation and quality of life for individuals with disabilities. The actual definition of disability or having a disability depends on where you look. And so what you find is that it's defined different ways on different types of instruments or for different purposes. In surveys and research, it generally is defined by limitations. In some policies, it's defined by a lack of ability to work. And then in clinical practice or diagnosis. Some folks, try and distinguish between having an impairment versus having a disability and how those fit together. I really want to, though, talk a little bit more about health disparities and healthcare disparities. There is a difference. What you find is that health disparities, or in the definitions, health disparities are the differences in the incidence, prevalence, mortality, and burden of diseases and adverse health conditions. You most frequently hear it discussed in terms of racial and ethnic disparities, and some in terms of gender disparities. It's a big, wide group of differences that are impacted by a lot of different things, including genetics, including the environment, including access to healthcare. Within this, you have the social determinants of health. Things like education, socioeconomic status, access to resources, and those all influence, once again, both health and healthcare or health outcomes. But what I really want to talk about and focus in on are health care disparities. That is, the differences in the quality and outcomes of health care services. And so you think about how health care is different or not different for individuals with different characteristics or levels of functioning, including disability. They're definitely one component of the larger health disparities, but at least in the environment I work in, the healthcare system, to me it speaks of what we can get our hands around or where we have direct influence. So once again, some of the social determinants of health include poverty, education, employment, where people live, suburban versus urban versus rural, and the access to resources that provides, the issues of power and vulnerability that impact someone's health status, as well as, once again, access. And then the access to healthcare, both as related to insurance, as related to location and policies. And then finally, the quality of that healthcare, what you get at various systems, how knowledgeable your provider is, how they treat you, all impact the final health outcome. What you find is that for all of these, individuals with disability have more risks and more vulnerabilities as associated with those social determinants. So individuals with disabilities have higher rates of early death, suicide and suicide attempts, hospitalizations, sedentary behavior, smoking, tobacco, preventable and chronic conditions, oral diseases. And once again, remember here that disability is not just physical disability. It's also psychological and emotional disabilities. It is sensory disabilities. And these are all clustered together when you look at some of the data that goes on. And then look at the outcomes between individuals with disability and the general population. Individuals with disability are also more likely to undergo severe medical complications, to self-report fair or poor health status, to experience social isolation, to report insufficient emotional support, and to identify risk factors, including alcohol, substance abuse, and domestic violence. I think it's important to keep these in mind. They have all these things that they're reporting. However, despite having no differences with regard to access to health insurance or our usual source of care, they're more likely to report unmet needs. And so you have increased need, but decreased access or decreased understanding or quality of care for this group. They're within the Healthy People 2020, you have currently 47.2% of adults with disabilities age 18 or older experiencing delays in receiving primary or periodic preventative care. And they're just trying to reduce that by about 5 or 10%. So you have insurance, you should be able to get care, and yet there are these unmet needs. They're less likely to use medical services associated with preventative care, have access to routine dental care, be counseled around issues of alcohol and substance abuse or smoking cessation, or receive treatment for psychiatric or mental illnesses. They also show fewer improvement on, so let me go back to this for a minute, because I do think it's important. So somehow, and I go back to this, despite having higher needs, despite being more at risk, this group of individuals is less likely to be screened, to be looked at for additional problems. And so you can't prevent things that you don't know about. You can't treat things or intervene. And there's a myriad of factors associated with this, but it's when this is the importance of we need to stop and look and say, okay, what's going on? What's contributing to this uneven presentation. There's more need here than with the general populations. Why aren't we tailoring what we do to this group? If we want to make an impact, this is where we should start, and yet we don't. So that's kind of the context of the need to be aware of and address the concerns of this group of individuals. So once again, individuals with disabilities show fewer improvements on quality indicators. They don't think they are seen as patients, as individuals. They're 10 times more likely to report low satisfaction with their healthcare provider and more likely to report those encounters being characterized by a sense of disrespect. You then have the compounded disparities and among individuals with multiple vulnerabilities or from multiple minority backgrounds. And so for all of the outcomes you see that we just talked about for individuals with disability in general, you find increased rates, increased severity of those issues for women with disabilities, for individuals with disabilities from racial and ethnic minorities, for those living in poverty, for children, for individuals who are LGBTQ, or in those based on geography, especially in rural or suburban areas. And so, you have to take in the whole picture and considering not just one aspect of the individual. Here, you can't say, okay, this individual is subject to this because they have a disability. They experience some of it, but then you hear additional layers and facets and components for individuals who are Black, for women, for children, for individuals with other characteristics. And so it was with trying to consider how all these factors fit together, with trying to think about the research related to healthcare disparities and translate that over for individuals with disabilities, that we came up with this model of healthcare disparities and disability. And this really speaks to, while what a person is able to do and their level of functioning, their activities of daily living, are definitely still impacted by their bodily functions and structures, by their personal factors, and by the environmental. That is really this interaction between the two that makes the difference and provides the opportunity to think about what we can change. In particular, when you think about, it's not one size fits all. I think the easiest way to understand it, or for me to explain, is that you can have the most wonderful doctor providing fantastic information and connecting with, trying to really working to connect with the individual. But if he's speaking in English and the individual only speaks Spanish, there's a mismatch in terms of needs, and that's automatically going to reduce or impact the quality of care as well as increase the unmet healthcare needs. You can think of the same thing as related to different types of disability. Once again, thinking of types of impairment, whether it's visual impairment or hearing or physical or cognitive processing or executive dysfunctioning. If we provide information in a way that the individual cannot grasp or understand, then everything that we're trying to do, or most of what we're trying to do at least, is lost. And I think that's often the state of our healthcare system. We build systems and structures without really thinking about the specific target needs and groups. And so we can really think about what are the fixed and what are the modifiable factors. Fixed factors are things that aren't going to change or aren't going to really change in a way that is easily changed. I mean, age changes, but we're not going backwards as much as many people would like to. Your past history is there, and you figure out how to deal with it and to move on given that. You're given a gender and a race, and while there may be influences on that, these are what we consider fixed characteristics. Our system is not there to change that. But then we think about what factors are modifiable. And these aren't easily modifiable, but this becomes then a point of entry. An easy one to consider is insurance coverage. You know, having insurance coverage does make a huge difference with regard to access to care and healthcare outcomes. Your attitudes and beliefs impact how you go into that clinical encounter with the provider and what you can take from it, as well as levels of adherence to the recommendations. Health literacy and psychological characteristics are all potentially modifiable factors for the individual. And then we have the natural environment. Here in Michigan, we know that the weather's going to come. There's very little that we're going to do to change it. But we try and think then about the things we can change to make it through winters. We create heated environments. We come indoors. When we think about folks with physical or sensory disabilities, we think about creating an environment that's accessible to them, that doesn't have stairs, that has doorways wide enough, that has amplification, so you can get the information that you need. So you think about those products and technologies, the human-made changes that we can create, as well as the people around you and how you can change those. The individuals in your environment are huge determinants of what you're able to do. And this is both those close to you, family members and friends, as well as powerful others. With the healthcare system, we think about physicians. We think about their attitude and their knowledge with regard to working with individuals with disabilities. And then we also think about the system, services, and policies. When we have policies in which you can only get rehabilitation, you can only get care before the hours of 5 o'clock, that kind of means that you either have to not be working or have to take off from work in order to access that service, in order to get a quality or a level of care that you may need to optimize your functioning and participation. And so we make choices. And the choice, how we make those choices, is worth consideration. Because it is this match. It's the match between who the individual is and what they need, and what the environment can provide. We have to think about that and do our best to match that interaction in order to optimize the functioning. And so if you think about low vision clinics, you think about, of course, you're going to have large print. You're going to have multiple modalities with regard to providing information and assisting people with writing or communicating or keeping track of that for them. But if we don't know and we don't think about those changes, where it's not going to happen. So once again, examples, video instructions for individuals with low literacy or low visibility often. That this method, you don't have to read it. You can get the information about what you need to do through a much more effective medium. But you have to think about, this is the group I'm working with, and this is what I need to apply. For individuals with executive dysfunction who can't just implement, okay, take your medicine 3 times a day, you have to think about concrete instructions. When can you take it? When are you at home there? Okay, you'll be taking it right after breakfast, right after lunch and there, and so you're going to have to bring it with you. And you help them really plan and provide practical information and support in order to allow increased adherence. And then for children, you think about how to do parallel for children and family members to have appointments in clinics after hours. So once again, you don't have to miss things that are part of your everyday life. And I would say this is really our responsibility as individuals and as a healthcare system. And so as students who are planning to work in the healthcare system, who are committed to working with patients, to helping people improve their health and their lives, we think about what we can do. We think about the changes that we can make and the steps we can take to reduce those healthcare disparities and to improve outcomes. It starts, I think, with increasing awareness. We have to first acknowledge that disparities do exist, and they exist on multiple levels. These are, once again, disparities related to overall health outcomes, as well as those related to our own implicit biases. Once we're able to do that, we can begin to find ways around it. But when we have blind spots, the patient is the one who generally pays. So we identify our own strengths, biases, and limitations, both as individuals and as a healthcare system. We increase awareness about those social determinants of health. I think it's too easy to say, well, this individual is not adhering because they have a personality disorder, because they don't want to. We blame the individual rather than understanding the complex realities in which they live that impact their ability to implement, or maybe even their willingness to implement, the health care recommendations. And then we identify information about existing programs, resources, and best practices. There are things out there in online, the webs, in communities. How do we get in touch with that? How do we know so that we can use it both ourselves and offer it to our patients? Examples are gathering and examining patient feedback, especially with regard to satisfaction with care. They have implicit bias assessments out of Harvard that you can go online and take related to a variety of issues, including disability, as well as gender and race, and really read about some of the healthcare quality and assessment reports. These things are real. The more we do surveillance, the more we see where some of the problems are. And once we know that, we can begin to address things. Once again, gather data, use appropriate and standardized measures. All measures are not created equal. You have to consider what is being looked at and how it's being assessed. If a measure is only available through or the data is only available via telephone calls that don't have TTY or don't have specific access for individuals in the deaf community, that's a limitation, and you have to consider how that fits in. If the measures include information about physical components, such as I move slowly with the measure of depression, you've got to think, okay, are there factors related to their impairment that also impact that? And then you really need to demand that the measures that you look at have been normed on a diverse group of individuals. Too often, I think the measure development says, okay, and we're doing a sample of individuals with disabilities without really consideration of, okay, so how many females, how many males, how many folks from different age groups, how many folks from different socioeconomic backgrounds or different ethnic or racial compositions. So it's standardized, it's normed and valid with that sample and with who you're working with. You want to document and conduct the assessments appropriately. You want to know who you're working with, what are your strengths or their strengths, what are their abilities and vulnerabilities, what interventions or services they receive, and how this impacts them. We'll see how long it lasts, but currently the Patient Protection and Affordable Care Act really identifies disability as a health disparity demographics that needs additional research and data collection. And it promotes or mandates the collection of data on the disability status, as well as the number of providers with accessible facilities and equipment. And this is really important. Once again, if you can't get in the door, you can't get services. One of the things that continues to shock me is access to a wheelchair accessible scale. And so something like 5% of primary care providers have a wheelchair accessible scale, which is important for monitoring weight, health. You think about diabetes or any changes, you think about medication dosage. These are some of the basic factors that we need to say, this should be universal. How do we make this as easy as possible? So these are some of the studies, I guess, in terms of identifying modifiable factors. The first referred to my own studies, what Erica mentioned in terms of the Department of Defense study I'm doing associated with cognitions, decisions, and behaviors. And so in that study, we're looking at success. We're looking at people who do well after spinal cord injury and saying, how can we help other people get there? And so we, as a psychologist, I think about how people consider things, what they felt, and what they tell themselves as the possibility for here are change points. Here are things hopefully we can influence, we can develop programs, and we can see what makes a difference. You know, for this group, you hear so much about family. Okay, what's your happiness? Family, friends. You know, it's not that much different from the regular population. What makes a difference, or the ability to create social networks, to have people who have your back if something happens. You're not going to do well after in living with a severe disability or impairment, or it's increasingly difficult, I'm not going to say not, to do that if you don't have folks you can call on to help if you need to. If your wheelchair gets stuck over, if your caregiver doesn't show up, if your tire goes flat or your van breaks down, you need to have a community support and structure, and family is part of it. And so for me, it's then thinking about the modifiable factors associated with that. There we have personality, which people may be born with, specific extroversion, need to connect, but there are social skills we can develop to make things better. There are ways that we can think about caring for and connecting and developing friendships and reinforcing those. That is modifiable. And so, we look at what we can do, and we start there. And then when you think about some of the large databases analysis, we can look at what are those factors associated within the medical expenditures panel survey or Medicare and Medicaid databases that impact outcomes. We can consciously create environments, just as we create environments which are inviting based on age or gender or race. We can do the same with regard to disability. We can think about not only the accessibility of an environment, the doors, the height of the table, the ways that we interact. We can think about the signage, the ease of use. We can think about the pictures that are up there, or how soothing it is, or how many things that bombard an individual. If someone has difficulty with sensory processing or with too much stimulation, having a loud waiting room, is not going to set them up for a large waiting room, maybe with lots of blaring colors or TVs, is not going to set them up for a successful interaction with their healthcare provider. Where others may be based on stimulation. So it's really knowing who you're working with, thinking about what are their characteristics, both personally as well as what are those factors in the impairment or impairment group that may impact their feelings of comfort, their success, their ability to communicate you and lead to better outcomes, more appropriate access and utilization of healthcare. And those are the things then we can begin to target and address. The research is, there's lots of research out there, but how much do we actually put it all together and translate that into creating spaces? We can think about the accessibility of services or the access for, I kind of mentioned earlier, the hours that we have, the cost of insurances, what insurance we accept. And then we can train faculty and staff to promote that services. how to use the equipment that you have, how to assist with transfers, how to communicate with individuals in multiple ways. And too often I think we depend or put it to the individual, to the patients, to figure out how to interact with the healthcare system, rather than saying, okay, they really have a lot we're dealing with. Let us take the responsibility. We know the research. We know the factors involved. Let us do whatever we can to optimize both their outcomes and their functioning. Once again, an example is just being aware of the standards on accessibility for medical and diagnostic equipment and following them. Having the right equipment in the room is a great place to start. Provider education, I think, is another area that is really ripe for being modified and for targeting for improving outcomes. And there are a lot of components to this. First, it can easily start by enhancing the recruitment, admission, and retention of individuals with disabilities in the healthcare field. If something like about 18 to 20% of folks in the United States have a disability, medical schools report anywhere apparently from 1 to 12% of their classes having a disability. And so where is that? Are folks not admitting that they have a disability because they don't want to ask for accommodations, because they don't want to be stigmatized in some ways? Are they being counseled out of those programs because people don't see them as able to perform, or they don't see the field or the classes as appropriate? And so there's a lot that we can do in terms of just on many levels, increasing role models, increasing the recognition of the accommodations that need to be provided with regard to the training, with regard to the testing, with regard to the timetable, as well as the practice itself. More and more, we're figuring out how to do practice in different ways, at a distance, in multiple different environments. We can figure out how to make the appropriate accommodations. We need to include courses with disability in the curriculum so folks know. Increasingly, it's wonderful that they're more patient-centered care, that the focus is increased on cultural competency, but we have to also include issues of disability so that when those implicit biases come up, we know what to do, or they've been challenged already and we know the steps. We've taken steps to address it. And this is so both providing it within school and then continuing education. Knowing the different types of disabilities and how it's defined. Knowing the difference between a medical model versus a community living model and all the factors in between. And skill development and hands-on training related to communication, related to facilitating self-management, and making how we provide the education to the various groups digestible and immediately relevant. Once you all, existing clinicians and future clinicians, get in the field, there's not a lot of time, and you juggle a lot of, or on the field they're juggling a lot of patients in order to meet their RVU deadline or guidelines, in order to see so many people, 20, 40 people a day, figuring out how to handle all the cases. How do we make sure they have the information that the providers need about each that may be relevant to enhance their access or the quality of care they provide to the individuals in front of them. So interprofessional training, and one of the examples is I'm working with collaborators in family medicine and pharmacy and information and such, to create an interactive e-learning courses for primary care providers to facilitate self-management of spinal cord injury. So this provides not only information about spinal cord injury, it also provides basics about here's what self-management is, here's the philosophy, and here's how to facilitate it in your clinical practice. We want to optimize the attitudes of all stakeholders. So promoting positive attitudes about disability, not thinking, as I've heard too often, from folks in focus group. Well, some folks think better dead than disabled. Some people think if you have a disability that you can't have a job, that you can't get married, that you can't have sex, that you can't have children, that you can't be a parent. Then all those things are possible. So if you're going to be able to provide appropriate treatment, the quality of care that someone needs, you have to promote appropriate and realistic expectations. This thing also includes promoting and working on self-determination rather than paternalism. We do a lot of recommendations as healthcare providers. We give a lot of advice. You need to take the medicine. You need to eat so many vegetables each day. And we all know we figure it out based on our current priorities and whatever we're demanding. Most of us don't do everything that we're supposed to, whether it's flossing your teeth or drinking water or eating vegetables or, the amount of exercise. You can't expect anything different from individuals with disabilities. You're people. And how they fit it together with handling usually much more complex healthcare demands or health behaviors is kind of up to them. They need to figure out the combination that optimizes what they value and what they enhances their functioning and quality of life. From my point of view, we have to recognize and support strengths. You go from strength-based model and what the person can do rather than what they can't. And you go from there. You're trying to eliminate judgment. Why aren't you doing this? And instead think, how can we get you working on a shared goal? What are the things that worked for you in the past? How do we build on those or fit this into your lifestyle? It's forming partnerships, providing positive role models, and really disconnecting the idea of, well, you just have a disability, you're necessarily going to have a lower or poorer quality of life. I remember really kind of being challenged with this by one of my students who had grown up blind. And I was providing data about, isn't this unexpected that individuals with tetraplegia report the same or higher levels of quality of life as the general population. And she was like, why is that unexpected? Why do you assume that just because you have a disability that things are different, that it can't be just as good? Or that how we perceive things, would be lower. So we can't assume, okay, of course someone is going to have more problems with weight. Of course they're going to be sadder or they're going to be more isolated. Those don't have to be the outcomes. There are a lot of factors in between, and there are factors we can do something about. I think for me, 2 examples of role models or 3. Here at the U of M, we have 2 department chairs who have significant disabilities, and they provide role models for medical students, for the providers under them. You have Dr. Corinne Morosco as the head of pediatric neurosurgery, who is living with spina bifida, and then you have Dr. Philip Zazoff as the head of family medicine with a significant hearing impairment. And they're breaking barriers, they're increasing awareness, and with them they're allowing other people to enter that space and say, this is possible, I can do it, and to get advice and that mentorship. And so having the faculty leadership of professional organizations. There are professional organizations for healthcare providers with disabilities, and they provide support, and it's unfortunately still needed because too many individuals with disabilities are counseled out at programs. My colleagues, one of them mentioned that he failed a course, not because he didn't perform adequately, but because the instructor said, well, you're taking up the space of someone who might have otherwise gotten into this program. These attitudes are out there. They're too often out there, and so we really have to challenge them. The peer mentor programs are fantastic. I hear over and over again that one of the key things associated with a success after a spinal cord injury was having someone else there, someone both to call you on your stuff and say, okay, deal with the grief, but then get on with your life. I've been there, I know, get over yourself. But also to provide that example of, it's possible. You can't tell me it's impossible because I'm doing it. And I think adaptive sports and recreation are also a great role model and potential, and I regret that I don't really see them here on campus. I think there are 12 or so colleges that have competitive wheelchair basketball teams. They provide scholarships for individuals who play this. And it's a great opportunity both to say, being healthy, being active, being an athlete, you can have a disability, doesn't matter. These are things we can continue to enhance and promote. Supporting families and social networks. For me, this was critical. I mentioned the study that I'm doing in terms of recognizing the importance of family and friends. Increasingly, studies in the United States are saying that folks stay close to home to provide the informal support that other family members need. Our healthcare systems relies on spouses, it relies on children of individuals, older individuals, parents of individuals with disabilities of varying ages, to provide the practical support and assistance that allow them to functioning. We, as a healthcare system, need to recognize this and do more to integrate that and to promote everyone's participation. We need to provide those information with the training, and with the resources to do it effectively and well. And then we need to advocate for policies and programs that recognize and accommodate the competing demands. Think about you can't bring young children into the hospital. So if your spouse is in the hospital for an extended period of time, what are you supposed to do with the kids? Who's supposed to take care of them? Who's supposed to take on the financial burden of that associated with everything else? When we think about, some of my study participants have talked about not just their health care, but the health care or ability of their spouse to get family leave and extended family leave, or how their injury impacted on their spouse's employment. And so all these factors combine. And we, as a healthcare system, we need to acknowledge the relationship. We need to say, and we need to figure it out. Because while we want to include the family, we don't want to disempower the patient. And that is a dance that sometimes happens. How much, if you have a patient with dementia and they say, okay, everything's fine, you don't just say, disregard that. But you ask for a secondary data source. Okay, your daughter's here, let me ask her too, or your healthcare, your home health aide. Let me get information from various sources so I can get a complete picture, so I can provide the most relevant type of recommendations, given what's going on. And then you also have to negotiate who's going to be doing this. If you want someone to get up and active and moving, what type of resources are associated with that? What type of manpower, and how do you help make that possible? You think about transition planning in terms of having a child who's living with a disability transition into managing their own health and into independence. You also think about transitioning into older adulthood and living or going on with more severe types of disability, or especially cognitive issues. How do you plan for that process and make it seamless, involve those people who need to, and see where they are within that? Think about school reentry programs, caregiver support groups, and really community events in which everyone can participate. Okay. I think we need to, and we can, develop and evaluate interventions and programs that provide the standardized ways of interacting, addressing, making a difference for both patients and families, that address relevant needs, that are feasible, relevant, and effective. And that consider cost, scalability. More and more I'm trying to do things that are web-based or online or using technology, because while as a psychologist I love the personal individual interventions, most people don't need that level of involvement. That, standardized education, support groups, ways of interacting that facilitate social connection are the piece that they need. And so we think about how to scaffold or how to scale the types of care or the amount involved so that it works and we provide people what they need, when they need, rather than saying one size fits all. You also want to consider problems with travel or transportation and difficulty coordinating schedules. And once again, not just between multiple patients, but between their multiple patients and the people providing them care or assistance, driving them to transportations or taking off from work in order to facilitate that access to health care. We think about self-management programs tailored based on age, health literacy, culture, or other factors. We think of gamification for teenagers, and so thinking about adherence or reminder programs that create it into a game. We think about prevention that help people get points and allow them to see avatars and such. And we think about culturally specific interventions that really leverage the strengths. Everyone has strengths. Everyone has norms. We want to recognize them and figure out how to make what we do better, how to enhance the outcomes for our patients. And I really think engaging and partnering with communities is key. It's not just that we go in and find out what's wrong and we do research and we write a paper and we put it on a shelf. We figure out how do we partner to make things better. We'll find out information, do research, and then we bring it back. Or they ask us for help, and we're equally willing to learn and take on the problems that way. We think about leveraging our expertise and resources to improve access, to develop programs that enhance strengths, to engage the patient and community networks. And I think I know Michigan is doing more of this, but these need to keep going on, and we need to not just have them come here, we need to go there and provide give back to those communities. Whether it's patient advisory boards or partnering with community organizations to provide skills that they don't have. And really then what I'm talking about is the knowledge translation, thinking about the creating or adapting clinical services based on the research evidence, making sure if you're collecting data, it's for a reason. And how is this going to change our practice? So you both have to know what is the existing practice, let's really describe that, and then what factors are relevant, and then begin to identify places that we can make a change, and then track the implementation of those outcomes. We consult with relevant stakeholders to promote those. The integration of technology, I think, is a big one, and the tailoring the services and programs, and I keep going there. What are the modifiable factors? What's going to make a difference for individual groups? How can we do that? One of the hotline SWAT team was the idea from a colleague that you can't have the expertise to work with every type of patient, every type of patient group. Here at Michigan, I know they've started to get more computer programs that tell about culture, but also getting information about, apparently the primary care physicians have hotlines of specialists that they can call and say, okay, there's this individual with spinal cord injury or Guillain-Barré, or what do I need to know with working at them? Too much, though, that too many people don't have that. Too many healthcare providers will go in and stumble because they don't have the information to say, okay, so why is this person feeling pain when they have paralysis and they don't feel anything, do they? And having someone there to ask questions to and explain things to them. So being able to receive trainings, to find the resources, to have the guidance that you need to make things better. Routine protocol screening programs, online machine training programs. And finally, in terms of reviewing and update policies, knowing what the policies of your department, of your institution, of the system you work in are, and figuring out how they impact individuals with disabilities, individuals with psychiatric disabilities, individuals with emotional, individuals with sensory, individuals physical, individuals with cognitive, how these work, you know? And then say, what can I do to improve them? Or is it this way for a reason, or did it just happen? How can I think about providing policies that promote access, enhance the quality of care, and doing the same at the state and federal level? And then advocating, taking the time to make that phone call to say, we need this. It does make a difference. You know, this is how all policies come to be. Someone notices. Someone says it can be better. It should be better. There should be a standard. And policies, if they're thoughtful and well done, do improve lives. And that's what we're looking for. So our challenge then is to work strategically to reduce disparities, to optimize functioning and participation. And I really think to create a model healthcare system in which every program and department is aware of and works to improve the access and quality of care for individuals with disabilities. There's some resources and references, but I think I want to just keep it there.